So I'm so glad to be here, and thank you for the society for inviting us and giving this opportunity. So just after the lunch, everybody feels like a little bit sleepy. So please welcome to Mongolia, of the beautiful country. So as you can see, there is a big lack between the urban and the rural areas. So that's why there's a big difference from the Mongolian medical fields and the population civils. So the Mongolia has a small population of 3.5 million with a high HPV and HCV infections. So that's with compromising the liver cancer is 39% of the all cancers. So that drives us for the need of the liver transplantation. So there are two centers actively performing the liver transplant, and till today we performed at the two centers almost 500 cases, but still not comparable with the other Asian Pacific countries. So our chronicle starts with the Samsung Medical Center, and thanks Professor Jae-won and Professor Kim Jong-ma and David Kwon and Gisun Choi, who's also here also. And after the training course completed, we started the first date in 2018. And the first 9 cases was performed with their helps and the bench side. And then since this year, the two and First Central Hospital and our hospital, we started laparoscopic donor hepatectomies with. So after just started the liver transplantation, there was a big pandemic. The COVID-19 was happened, so the numbers were not increasing. But after the pandemic was ended, we routinely starting performing each case per week. So now we have almost 200 cases, but it's very low number of the cases, so we have a very small experience on the bench surgery that today is my topic. So our philosophy is try to transform the complex anatomical gift into a simple, safe, and a standardized, recipient-friendly organ. So as we have a resource-limited country, so we try to use everything less and much more less expensive for surgery, the cost effectiveness also. So we try to solve the problems before they occur. So the bench surgery is also playing crucial roles to not pass the complication and the stressful life after the transplantations. So it's a proactive work, and the fundamental is to fit the organ to the recipients. And the secondly is to simplify for the safety and the speedy also. So the philosophy is also one in and one out, and trying to maximize the gift of the donor, because of our population is 3.5, so we don't have a second options much more. And also trying to customization for the anatomy of the donor and the recipient size too. But even with the limited resources, there are basic instrument for bench surgery is similar as the other countries, so that is not much a problem. But one of the issue is we don't have the whole country. We don't have a tissue bank, so we don't have cryopreserved vessels, and due to some social mal-understanding of the journalists and the surgeons, last 2 years we have 0 cadaveric donors. So now the situation is really difficult, and the only graft we have is artificial grafts, PTFs. So the key steps of what we perform is similar as the others, because all our basic technique is learned from the Korean teams, from the Samsung Medical Center and SNUH also. The basic philosophy is if we have more than 5 millimeter of V5 or V8, we try to reconstruct by using the artificial grafts to the right hepatic vein outflows. So here's one of the cases that we are trying to advance in our small experience, because in early experience, it's always the learning curve trying to teach us the only single artery, single portal vein, and single hepatic vein is best choices. But in the real life, the donor comes always with two bile duct, two artery, or two portal vein, or different hepatic veins. So the life challenged us to advance in the more. So we try to expand our criteria with the two portal vein for the type 2 and type 3 portal vein variations by using the venoplasty, by unification, and also the patch venoplasties. For this case, we used patch venoplasty by umbilical vein graft for when the two portal vein is the size between the two portal vein is more than 5 millimeter. We try to make the patch between the two anterior and posterior portal veins. And in that case, there was a inferior hepatic vein, so we closed the one from the segment 6, posterior segment 6, and the dominant segment 6 and segment 7 inferior hepatic veins was reconstructed by using the artificial vascular patches. So when there is a two portal vein and the size between the two, each of them is less than 5 millimeter, we try to unification by opening the longitudinal, the anterior wall of the two portal veins and suturing for the unifications. For the bile duct reconstruction, as early method, we try to using the ductoplasty, and also as Professor Lee taught us, the TTA tailored bile duct anastomosis. But now we're trying to anastomose the original anatomical, keeping the original anatomy. So when there is a two bile duct, we try to anastomose by when the size between is more than 1 centimeter, we try to perform it at the anterior or left side. Each duct is separately anastomoted. But we never try to ductoplasty between the two holes, and now the challenge is really expanding to keep the anatomy as it is. So in the conclusion, as we have a lot of experience, so we always try to perform the surgery before even the surgeries. So as Abraham Lincoln said, give me 6 hours to chop down a tree, and I will spend 4 to sharpening the axe, and also trying to make simple as possible, not selecting the simplest cases. Thank you very much.